on the other. Okay, I think we're back.
Yeah,
okay,
back.
Great. Good. Okay, well, nothing happened while we were away. So we'll start with introductions again and welcome. So my name is Mindy Tueller. I am the facilitator of this group, and I also manage the Medical Portal, which we hope is a tool that will be of help in your efforts to coordinate care and do your jobs, and we'll certainly see the Medical Portal a little bit more pretty much in every meeting. And so perhaps we'll just jump straight to the people on the phone and ask them to introduce themselves. And again, if you'll speak a little bit loudly so we can all hear.
Tony, you want to go ahead? Or Becca?
I'm Becca from the University Pediatric Clinic, a care coordinator.
Welcome, Becca.
Then we have Melinda. Yeah?
Hi, I'm Melinda, Utah Valley Pediatrics Timpanogos Office Care Coordinator.
Hi, Melinda. Tony? Well, we have Tony Estrada on the phone.
Okay, great.
She might have some difficulties.
Okay. We're happy you're with us, Tony. Tony's with Integrated Services. Anyone else?
No?
Okay. Super.
Not at this point.
Yeah, did you want to go ahead and start?
Okay. So my name is Gary Baragushi. I'm one of the UPIC QI coaches and assisting Mindy with these meetings.
Gina Polo, my Utah Family Voices. Marilyn Howe, Integrated Services.
Can you guys please speak up so that people on the phone can hear us?
Marilyn Howe with Integrated Services in the state of Utah.
Perfect.
Thanks.
Walt Torres, Children's Special Health, also with Integrated Services.
Maria Castro, I'm care coordinator at South Main Clinic. Tina Smith, I'm the supervisor over care coordinators at We Care Pediatrics. Claudia Fruin, the medical director.
Chuck Llewellyn, Director of UPIC.
Julie Olson with Medicaid. Don Dowling, I'm also a QI coach with UCCCN. Sharon Erickson from LCU. Jake Porter, pediatric care manager with LCU Medicaid. Jenna Robinson, I work for Washington Pediatrics at South Point. And I'm Jenna Dilworth, and I work at Wasatch Pediatrics at the St. Mark's Clinic, and I'm the care coordinator there. I'm Kay Haynes with Resources for the Medical Health Board. I'm Lori Lunt, and I'm with Wasatch Pediatrics Health. Excellent. Great. All right. Okay, well, we've got the agenda posted up here. We're a little bit late, so we'll see how we do, but hopefully we'll see our first presenter wandering in here in just a minute. We'll have him tell Ben to talk a little bit about brainstorming, which is our opportunity to talk with you guys about any difficult cases you're running into, any kind of place you're stuck, looking for resources for families you work with, anything that's difficulty that we can network about, come together and see where you can help you and identify things that may or may not be in the medical portal, and if they're not, we get them there. So, does anyone have anything that they're struggling with right now? Any difficult cases? Any seeing for your families that you're not finding big needs? Yeah. I struggle with them. Okay. There are resources. Remind me, you're like I'm at with health schools, but not just medication. Right. Also with our health plan. Okay. And actually, that I'm having struggles with because we do have a cap on what we provide, and then she can pay out of pocket, and it's expensive in the case of this particular family, and that's one of the requiring speech therapy. And so every year they use up their allotted business, and then she pays for a certain amount more, and then he regrets, and they start over the next year. So she said it's just so hard, and the older he gets. How old is he? I think he's 9 or 10. Okay, and where do they live? Out in the southeast of the valley. Okay, but in Salt Lake? Yes, Salt Lake. Okay. So one of the things that I would assume is that they want to stick with the same speech therapist. No, you know, she wasn't particularly. I mentioned that to her. Mm-hmm. She's not big on that particular program or whoever. She's just really big on it's so frustrating, so hard. It's making a bigger difference. Oh, I'm sure. Does anyone have any ideas on what this family could do in terms of? I wonder if they could apply for. I'm not sure if they call it a grant or scholarship. As long as they have commercial private health insurance, they can apply for that. And it doesn't matter what. Yeah, as long as it's covering things that the health plan's not covering. The other thing would be to address if the child's on an IEP and if there's goals specifically stated in there for speech, because if it's impacting his education, then they need to recall an IEP meeting to set those goals. On the outside, Scottish Rights in the past has offered free or low-cost speech therapy services for families to try to help supplement what they're not getting in the rest of it. There's usually a waiting list. And there's a waiting list, as with anything. Right, especially with no cost. But to get on that waiting list and move up the list, even if you don't need it, then you can say no thank you. But typically, you always need more than what you get. Yeah, they're only there for the educational purposes. Becca is hoping we can restate all of this. So, is it Sharon? Sharon with University Health Plans has a family she's working with, Becca, and those of you on the phone that has a boy with autism. He's around 9, and they have a limit to how many speech therapy sessions they can have every year, and after that it's out of pocket. And so it's been very difficult for the family to keep those regular appointments, and when they stop because of the financial hardship, then the boy regresses. So we're trying to come up with some ideas on how to bridge the gap. And so we talked about United Healthcare applying for a grant to United Healthcare Foundation, and also Scottish Rights Children's Learning Center. Somebody's getting on the waiting list for that. It's always a nice way to sort of have that. Oh, but you know what? They don't take children with autism. Scottish Rights. They don't. It's usually neurotypical development with a speech or language learning disability. My understanding is that not with autism. We'll look into that. We'll clarify that. Okay, thank you, Marilyn. Yeah, Lita. With the Autism Monday, isn't that going to change? We're supposed to change that? I don't know. The health insurance plans can set up what they will cover. But I thought the mandate will make it so they have to accommodate?
The mandate just says that we'll cover if they are one of those few insurance companies that are not self-funded or in a RISA plan. I'm not sure about the U of U, if it's self-funded or if they just set their benefits package for autism. So, and they're from the health plan, so it'd be interesting to see exactly how the mandate.
So it is an at-risk plan. I think that means self-funded, but I don't know. And I don't know, what age do they have to be to go to the University of Utah, the OT, the life skills program, that is on Wakara Way? I've been on Wakara. But if you call the university high school main number, they can connect you with them or direct you to give you the information. Because we have one of our district boys going there for teaching on teachers. Those fees.
So we'll see the 18 years.
Is that low cost or no cost? Life skills, you know? Well, that's what I'm still going to have to pay. Oh, yeah. It's not what I'm insured. I don't see anything on there about speech therapy on the life skills clinic. Well, yeah, because we got the report from the speech therapist that you did. Okay. Well, we're not getting that with me, but I'll find you. What's that? It sounds like we need to inquire more about it. Update it. So that's great. So those are some good ideas. But I wanted to just ask really quick. Sorry, Gina, to put you back on the spot. But if an updated IEP says that a necessary requirement, then what? Well, they'll have to relook at what the goals, all of that are, and again, it's hard because the school is doing looking at how the speech therapy services needed to accomplish it at the position. So we all know that that's all from what the child is. But if the child is regressing, the parent can request that the school relook at that and call a new IEP meeting.
Yeah, we requested one of the schools, and they said that that's all they could do. Because they don't have the manpower, they just don't have enough personnel to do it. So once a week, it was all the speech therapy that this child was getting.
But it's probably still worth looking at.
Oh, pushing it, yes.
And pushing it, it's the law states that they can't say that it's a lack of resources. Like they've been telling me that they really do need to, by law, meet the needs of that individual child. Now, if they've done testing and said this is what's needed, his needs in the school, that's a little bit of a harder fight.
And the team has to decide if they want to do for the summer, and they not necessarily just across the board they will qualify for extended year. But even so, summer programs are only Sure, what we'll do is put together, everything that's been said here. And they offer, and then we'll send that around to the about 20% of the month. So, good. No, that's a good one. That's always helpful to understand or try and understand what is supposed to happen and what you can do. Well, timing is perfect. Our next presenter is here. So, Jason, I'm going to actually give you the podium a minute or two early because I feel like what you have to say is of great interest to everyone. So, I think you should be ready to rock and roll. So, everyone, this is Jason Fox. He's the Division Manager of General Pediatrics at the University of Utah, and someone who has a fair amount of experience with this kind of staff billing and so forth.
Good morning, everyone. Thanks for letting me come present. As Mindy said, I'm the division manager in general pediatrics, and this chronic care management code, these are something that we've kind of been playing with for almost like the last 2 years. We've been trying to find ways to bill for care coordination in our clinic, South Main being an example. First thing I want to say is, so this is just my explanation of these codes and how to use them based on my understanding. Essentially the research that I've done on my own and also the interaction with our medical billing team at the university. We are lucky enough within our division that we have a pretty complex billing team that's able to help us work through these things, so we have some resources. And then I would also just say to please research and use at your own risk. So the first thing, so this is the CMS language for the CPT code 99490. I'm not going to read this verbatim, I'll let you kind of just go through it. But essentially in January 1st, 2015, Medicare did set up a CPT code that could be used for non-face-to-face care coordination. The second thing about it is essentially it needs to be at least 20 minutes of clinical staff time directed by a physician or other qualified healthcare professional per calendar month. And the other thing is that it requires 2 or more chronic conditions for the patient to have that are expected to last at least 12 months. Chronic condition, and then also comprehensive care plan established, implemented, revised, and monitored. So the way that I've defined this is essentially for CPT 99490, to be able to bill for it, you need to spend 20 minutes of non-face-to-face time in the calendar month doing care coordination. The patient has to have 2 or more chronic conditions, and also you need to have an established and maintained care plan. So some of the things to consider. So for most of us, when we're talking about Medicare, that really usually doesn't impact our population. I would think other than end-stage renal disease, I don't think any children are actually eligible for Medicare. And again, that would be like probably a handful of patients in any practice. But with Medicare covering it, now Utah Medicaid has also decided to reimburse for this CPT code. And it's my understanding that that's now a traditional Medicaid. So meaning any of the ACO plans should also have to pay for it. If they're not, it would be something we would want to discuss with each payer. And this doesn't mean that commercial payers have to pay, but they typically will follow suit with CMS. Usually, like CMS comes out with a guideline, and within a year or two, most private insurances are also doing that. CMS does actually require a signed consent, and so from a university perspective, we've also been told by our compliance team that we need to get a signed consent for any patients that we would do this on. And then the other thing to remember is not for your Medicaid kiddos, because for traditional Medicaid, they're not going to have co-pays. But for anybody that's on a commercial insurance plan, they definitely could be subject to either a co-pay or co-insurance. So that's another thing to consider when we're talking about the consent. So the signed consent includes informing the patient of what you're doing, obtaining a written agreement. I was just in a meeting with our compliance and billing team last week, and they were deciding to tell our organization that in terms of informed consent, they really want the provider to be the one starting the handoff. So at least talking about it and then handing off the care coordinator to do everything else so that they know that it's coming from the provider. And then also in the EMR, you need to document the discussion and the patient and their decision to accept and or decline. And then you also need to be able to give them an explanation on if they want to revoke the service, how they would do that. And then the signed consent also includes informing patients that only one provider can bill during a calendar month. And I'll try and briefly explain this as best as I can. So essentially, multiple providers can bill for the service. The way that it will work is you would have to technically have the signed consent on file, and then the person that bills the CPT code at the last, whoever billed it later in the month would actually get credit for it. How they figure that out and pay for it at a Medicaid standpoint, I have no clue, but that's what they say they do.
Is there anything in there about balance billing? Medicaid doesn't do it, the commercial payer charges it, and the payer doesn't pay it, or are you contractually obliged to charge that benefit?
From a university standpoint, we would say yes. I guess it's so university standpoint, it may also depend on the size of what we actually bill out, because the university typically anything under like $25 gets written off and never actually gets billed to a patient. But yeah, I mean, I would think if a commercial payer doesn't pay it, then it could definitely end up just patient responsibility 100%. And in that case where it's not covered, it may not actually apply to like a deductible or a coinsurance. So for example, I think non-covered services typically don't meet like your deductible requirements, so it could be something that's charged every month. Mindy and I talked about this, and I think I have like a brief explanation of a way to maybe address that. This is just an example of a consent form, and I also gave Mindy the links to these, I think. So they should be made available, but we have a consent form in both English and Spanish. And this is the same consent form we have on the South Main Center. So some suggestions. Back to that. So suggestions, the first thing is to have the consent on file for all patients. Within Epic, we have like a media tab where we've been advised to scan it to so that anybody could just go to the media tab and find it. Also, in a system as large as ours where there's multiple providers, you could also see what other clinics may have it. Comprehensive care would be a good example. Some of your practices that are also in the comprehensive care program through the university, and I believe they are actively billing for these codes as well. And so Chuck, speaking to what you mentioned, a suggestion would just be to advise the family that there may be the copay coinsurance, and document this discussion occurred. What Mindy and I talked about was discussing to a family why this is beneficial. So for kiddos that are complex, explaining that this month-to-month, day-to-day management is better for their care, and that by doing this, we can hopefully, get their comprehensive care plan worked through all problems on there. It's probably not the best answer, but I think just explaining what the benefit of the value is to the patient and their family. Hopefully, they'll be open to that. And I don't know, so in the university world, we're told that we can't necessarily write anything off. That isn't always the case. We can usually do courtesy write-offs or courtesy adjustments. And I would assume in a private practice, you probably are, I don't know if you're open to being able to write things off more liberally or not. So I don't know if that would be possible. So reimbursement. So I just double-checked on these in the last couple of weeks. And as of January 1st of this year, so the Utah Medicaid shows a reimbursement rate of $33.65 for this CPT code. When we build these through the university system, so this includes Medicaid and all the commercial payers that we deal with, we saw reimbursements anywhere from $33 all the way up to $80. And then I don't think I'm supposed to tell you exactly what we charge on the university fee schedule. I think you can find that information. But I'll say that we charge close to $90 if that helps for practices trying to decide what charge factor to use. And then, I don't know that I mentioned, but some plans have denied. Those included commercial. And then interestingly enough, we also saw some of the surrounding state Medicaid plans from one of our largest deniers because we were focusing on the Medicaid population. And I don't know, every Medicaid state to state is different. So with Utah billing these codes, it doesn't mean that Idaho Medicaid has to, or Wyoming Medicaid has to, or Nevada Medicaid has to. And those are where we're seeing some of our denials. So in terms of how to implement, we started, so we have two clinics that we're doing this in, South Main Clinic and then also the University Pediatric Clinic. We really did try and start very small with pediatric fashion. So in each clinic, we were usually working with just one provider. They would identify one patient that they knew qualified for the service so that we could try to bill for. And then in addition, we would just add a few more kind of month to month. So we started by actually tracking this in Excel as well as our EMR, and that is both what was being performed and the time spent. We were told that we had a function in our EMR Epic that would track it for us, but it never actually worked. We were able to put it there, but it wasn't able to be tracked by our billing team. So that's why we would do it in Excel as well, and then we would just send this information to our billing team every week, and then they would drop the charges for us. I don't know if this is an EMR technical thing or not, But within Epic, so we talk about any healthcare professional being able to actually do the charge, but within Epic, the physician actually has to drop the charge or drop the bill. So, like for example, if Emily, Lisa, or Maria are doing the care coordination in the clinic, they would be the ones that are actually tracking it either in Epic or on Excel, but then they would have to hand it off to the attending provider. So Dr. Hobbs would be the one that actually physically drops it in Epic. And then we also work with our IT and our billing team to determine where to house in our EMRs that billing could automate it monthly. And this is, again, we've been working on this for 2 years, and it's my understanding that we are, Epic has something called Healthy Planet, which is getting ready to roll out. And I believe Healthy Planet has this built into it where we can actually do it within the EMR. But honestly, tracking it in Excel is just as efficient. And you have, I think, just as much ownership of it both in Excel as you would in your EMR. So again, on that, I would just say starting small, like trying to do PDSAs with one provider, one patient. The other thing is you'll probably have more control of it if you're going to start billing these codes and seeing how the reimbursement comes back instead of doing them all at once and then 75% of them denied, and then you have to explain that all those families that you just billed for, why it wasn't covered. So it might be better to do it small and just start seeing what the reimbursement coming in will look like. In addition with the Medicaid, like, so for example, it's my understanding that traditional Medicaid does cover it, but you may actually get denials from the Medicaid ACO plans that they're on, and then that gives you a chance to work back and forth with those plans and say, hey, we built this for Medicaid, it's covered, why is it denying? Would be my suggestion. So the outcome, I did want to let everyone here know, so we actually do have a contractual relationship with one of the Medicaid ACOs. Doesn't need another power source. So we have a contract in place that they help us with our care coordination costs from month to month. So as a result, we've been working on this for about the last 1.5 to 2 years within our division. So at our 2 clinics, we actually currently are not billing through the CPT code until we resolve how this might impact our contract with our Medicaid ACO. So we fully expect that we will again revisit these codes, but currently right now we are not. But we do work directly with like the billing team and then also the university on like a steering committee to see how these codes are implemented. And in addition, I don't know if it's worth mentioning, but the Nancy Murphy's comprehensive care program was within our division and has now moved on to its other division. So we work closely with her in this regard and actively billing these codes. And this will be fine because it's a segue into the next part of the presentation. Are there questions at this point that maybe I can help answer? Emily, Lena, Maria, any comments on doing this? I know it's kind of been like start, stop, go, yes, we're doing it, no, we're not, but.
You said a care plan has to be in place. Is that just the plan from a visit, or what specifically does that entail?
So this code isn't as specific as some of the other comprehensive care codes or complex care codes we're going to get into, but it just says establishment and maintaining of a care plan. That's the verbiage. So I think it's probably somewhat open to interpretation. Like it doesn't say it has to have X, Y, and Z. I know within like the medical home demonstration, we just work on care plans that have X, Y, and Z that we were working on, and I think that would probably be the best way to approach it. I'll talk about it as well, but in my mind, like if you're doing a systematic approach and if you want to build these codes, probably the best way to do it is to define the population where you can probably work on these kiddos every month to be able to bill for them. So in that regard, I would think like your most complex kiddos that might have like 20 things that you want to work on. When I've talked with like our billing and compliance teams in our meetings, what I've explained to them is for a lot of these kiddos and these families, if they have 20 things that they want to work on, they're probably only working on the top 1, 2, 3 that are most important to them, right? Because they know that most of our families, they have so much going on that it would be really hard to get everything done. But if you can really, sit down and establish a comprehensive care plan, that really identifies even the goal, like those pie-in-the-sky things that they wish like one day they could manage, and then just for month to month just try and knock those out and get farther down the list. I think that would be the way I would handle it. So again, I would think if you really can have them come in for that visit and really establish like a very thorough care plan, not just the things that they're managing right now or want to manage next week, but the things that they envision like months or 2 years down the road. That does bring up also, it's my understanding of these codes that in order to get the signed consent, the first visit is supposed to be a face-to-face visit. I always try and do things as simple as possible. The first question I said was, can we just call them and get the consent email to us? And they said no. From a compliance standpoint, they don't suggest that. So they really ask for it to be a face-to-face visit, and that's why we talk about having it initiated with the physician. So maybe if it's even at the end of the visit, they're just saying, hey, this is something that we're working on, and then they're bringing in the care coordinators. But that's kind of how I would look at it.
Are there documents for what this care plan is supposed to do? Did anybody publish that, or is that part of it?
So there's not on this one. The next code that I'm going to get into, they have a little more description that I think is a little bit more meaningful. And I do have a link that goes into much more detail that I think is actually published by CMS. So it does go into more detail, and I can't speak to it as eloquently as the handout can, but there is a link to it. But yeah, I just tried to take out the basic, which was establishing and maintaining the care plan.
I was just thinking of this, that something probably familiar with too, but for the chronic conditions, and what if it's something like sinus bifida and it's minor complications, so she doesn't have like asthma and sinus bifida or heart, but with those, her bowel and bladder complications aren't going to go away, so it is chronic. Do you think that would? Yeah,
I mean, there's essentially, if somebody's chronic condition is any condition that's going to last at least 12 months and or until death. So yes, as long as it's something that lasts 12 months, it should apply. And it's my understanding, based off what I've read, just because those are the two conditions, if you're working on something else, that doesn't matter. Because there's other things going on with the kiddo. They just have to have two or more chronic conditions. So I think where you're seeing, so like we don't have to be working on the bowel problems every month to build a code. They just have to have the two chronic conditions.
Jason, I have a question. In terms of documenting the time spent, is there like a specific criteria to do that, or once there's a care plan, does that go included, or?
So in terms of criteria, my understanding is it just has to be documented. We looked at a few different things. These next couple codes that I'm going to look at, they were actually 60-minute and 30-minute increments. So we kind of decided that we wanted to look at everything in 15-minute increments. This 99490 is a little tricky because it's 20 minutes. So, I mean, depending on what you're going after, it probably just depends on what you're trying to do. But, I mean, just establishing that time is being tracked is the main thing. It's not like it has to be minute to minute. And I think in most of, like, the verbiage that comes from the insurance companies, like some codes say 20 minutes or more spent. So I think just establishing that at least 20 minutes was spent, however you want to do that. This is what I was just talking about, but I think in the ideal world, we would have our clinics, our robust registries of our children with special health care needs. We'd probably be working with the insurance plans on them as well. Again, I would start with your most complex and then create and update comprehensive care plan. Again, in my perfect setting, I think if I were to deploy my care coordinators, I would probably have them splitting their time between focused care coordination on our children with complex needs that can be billed for each month, and then day-to-day coordination that occurs. So, I mean, when I think it through it in my mind, I really think of like a 50-50 split between doing this that you know you can bill for, and then doing just the day-to-day coordination that I'm assuming a lot of care coordinators actually do in the clinics when kiddos are just coming in for visits. And we've tried to run the numbers looking at, you know, like how many X amount is this equal per month. And I guess that just kind of depends on what you're looking for. I mean, I'm assuming in a lot of these clinics, care coordination is already paid for, or in some way. So I guess it's like, are you trying to 100% cover the cost of your care coordination, or are you just trying to supplement 50%? And that's something that I think is kind of decided at the practice level. And each practice is going to be different. But in my mind, in running the numbers, if we spent about 50-50, that would usually fund like one full-time care coordinator with salary and benefits within our organization. And then the last thing I just put is creating monthly dashboards to monitor progress. So again, we went through and said X amount of kiddos would have to be done per week, per month. And those are things that I would monitor, you know, at the clinic level with clinic management, with the providers, and also the care coordinators themselves.
When you were running that math, how many patients?
Ask a question, Chuck, that I don't have on me, but let me see if I can do it. So in my math, like to cover it completely, you would be having to do 20 kids a week, so almost 5 kids a day. And then, so we were looking at, I was thinking probably half of that, again, because in my mind, the 50-50 split, knowing that we already have farms that have been like, kind of dedicated to the division department level, which is but I think for the full-time coordinator, it was 20 kids a week.
So these would, you're talking about a combination of all of these codes?
Just this code specific code.
I mean, we're thinking it.
Actually, can I not commit to that number? But because I'm just trying to do it on my calculator.
Yeah, but I think it's, you know, the math becomes they're doing any of these, a fair amount of investment in systems and processes to make sure you get it right, so they can get audited and come through clean. So I mean, if we're talking about if 20 means 80 a month, and that 80 a month that are billed monthly, then that gives one a scale, you know, sense of scale about.
So yeah, so looking at it again, so 20 a month, 20 a week is the number that we were looking at, kind of bottom to cover at almost essentially 100%. That's assuming we're only getting Medicaid reimbursement. That doesn't include the commercial payer mix, just because we haven't billed robustly enough to know for sure what our commercial reimbursement was going to look like. So that's assuming you're getting a Medicaid reimbursement. And with that, I'd probably say also we'd probably assume like we're getting an 80% collection rate to kind of take into consideration the commercial people that aren't paying on it.
Go ahead. Are subspecialists planning on using this management code at all?
So yes, that's an interesting question. So when you actually, if you go follow the link to the actual definition of what these codes are for, this code specifically was designed by CMS to manage chronic care within primary care patient settings. That being said, I think if it's worth it, some of the chronic management clinics also will. So for example, comprehensive care program, they're actively billing these codes right now. So I'm assuming other practices would if they know that it's out there. And that's where we've had a discussion at the university level because, again, the real meaning for this code is to manage chronic care and primary care settings. But it's also a Medicare thing, so this is really aimed at the adult population. I mean, if you're speaking to the language of the code, yes, it's to manage chronic care and primary care settings, but that's probably because at an adult population level, there may not be the complex settings for, I think when you look at it, I want to say they say like at CMS Medicare level, almost 60% of patients have 2 or more chronic conditions. So it's almost like as you age, you're more likely to get a chronic condition, which probably has to be managed in a primary care setting because there may not be other avenues for it. Whereas in pediatrics, when we have so much focus on specialty care, it kind of flips a little bit. And so I hope that answers it. I would assume some would. The language is for primary care, but if I was the manager of a comprehensive clinic, I would probably want to.
Well, will the insurance company only pay only once a month to a particular
provider? That's what CMS says. And so if CMS is saying that, Medicaid should be following. In terms of private payers, I mean, they can follow CMS guidelines or they can choose not to. It's completely up to the payer. And I don't have robust information. I don't have that robust information to know like Blue Cross will pay for it multiple times per month versus not. But at a Medicare and so Medicaid level, they're saying only once per month, and the person that bills it last in the month would get it. So if Lisa has a kiddo that's seen on the 15th of the month at South Main, and then they go to comprehensive care program up at the U on the 25th, whoever drops it last is the one that gets it done.
Yeah, CPT code is written as a
coordination, who's one that's billing for this?
It should be. What we've just, I think what we've discussed in, and again, this is from a university setting where we have primary and specialty care settings all kind of working in the same group. But we've discussed, like, if, for example, if at South Main the patient does qualify for a comprehensive care program, whether or not they go there or not, if they've established care there, we'll let them bill for their code. But if they haven't established care and they have two or more, or if they have the conditions to get into the program but they're not into it, we'll bill the code. And this is something that actually just came up in a billing meeting last week at a department level, because the same question came up. Well, hold on, who's supposed to bill for this? And again, in the primary care setting, we understand what the language of the code is, so we feel pretty adamantly that at a primary care setting is what it should happen. Jay, did you have any more questions?
I just think it's great. With the neurology clinic in the adult population, we spend hours on the same patients every month.
Mm-hmm.
So they'd also have an immunologist or an endocrinologist or rheumatologist and a primary care doctor, and each one would say, oh, well, this isn't my specialty, you need to go. So having a way to kind of convince the primary care doctor that it's worth their time to actually coordinate the care, that would change a lot for patients.
And the one thing I would add, so I mean, I work at the university and involved in the Department of Pediatrics, and I know that at a department level, like I sit on kind of the steering committee to try and figure this out, along with only Nancy Murphy's comprehensive care program. So I don't know if the other divisions within pediatrics, so like neurology, genetics, metabolics, are billing these codes or not. I don't think they are, because as an organization, we haven't really decided what we want to do. So I don't know who here is in like the private practices, but if I was in a private practice, I would probably be trying to go after these more aggressively now, knowing that people are less inclined to be doing this yet. And so your chance for reimbursement is probably better. And then also, if you have systems set up, you may have more of a bargaining power down the road to work with chronic care management clinics. So like neurology and genetics, saying that, we're actually establishing the care, work with us, we'll do this every month, and it should save you time and make your clinic more meaningful. Because I think at the neurology level, let's take like genetics or metabolics. I mean, I understand those clinics sometimes have like year waits. And so I'm guessing they just manage their population they see every day. I'm assuming they're not managing their patients month to month to month to month. I could be completely wrong on that, and if anyone wants to speak to it, correct me, that's fine. But that would just be my assumption.
University medical billing has done some comprehensive care from
That's what happened. So that actually came up in a meeting with billing and comprehensive care and South Main last week. And so they're making a decision on that. But again, I think it really is the last person to bill it in the market currently.
I think what that might also help with is we have families who go with the same issues to all of their providers, but having one designated to be the touch point, and say, yes, we'll talk with your care coordinator, yes, let them know we're here and call us, but designating who's in charge of coordinating your care, that'll save the family's time and maybe help with their care being more efficient.
Yeah, and I mean, I agree, and I think so on the month, so we have a monthly meeting between health plans and our clinics, and that's exactly what we're doing. We're discussing like, oh, kiddo was seen here, kiddo's going to be seen there, and I think that happens best at the primary care level. That's what it's really meant for. So yeah, I agree.
Well, I can tell you, I came from the case in the ABS program, and we took calls from those other clinics.
Yeah. And
we had to chart and help to so we bill for the calls.
Yeah. Okay, yeah, that would be my assumption. So again, we've been doing this for almost the last 2 years. Again, we were doing this at two pediatric clinics concurrently. In terms of the scope, we work with both our IT department, our billing department, and then also just continually through the process. We would meet with our different groups monthly. And in that 12 to 18 months that we were really kind of actively trying to do it, we billed roughly this code 40 to 50 times. And this is, so Chuck, this is the reference that explains everything for this code specifically. So it does come from CMS. It's like a 20-page handout, and I think Vicky will be able to provide those links for that. But it can hopefully kind of answer any questions like clinically that someone might have. So this I'm going to go over more briefly. I think I've got about 5 to 10 more minutes. That sounds about right. So these are two other, these are going to be two codes, so 99487 and 99489. So the first one, 99487, is for billing 60 minutes of clinical staff time per calendar month. The same thing, it has to be 2 or more chronic conditions. And this is where it's a little bit different than the 990. And so this has to be establishment or substantial revision of care plan. And this says moderate to high complexity medical decision making. And these are kind of questions that could be open for discussion that you would probably want to be making at like a higher level, making sure whoever's signing off on this code really agrees that this is a substantial revision or moderate to high complexity. The way the language was written, so in speaking with our compliance people, we were actually asking them this question: what is substantial and what is moderate or high complexity? And so they would actually just review our code. They would review a chart and they would tell us if it met the criteria or not. So this is a little bit more technical, and so that's why in terms of which codes to use, I like the 99490 because it's talking about establishment and maintaining the care plan. There's not words like substantial, moderate, or high that could potentially get you into trouble if you're not doing them correctly. So let's see. So then the 99489 is a code that kind of goes with the 9987. And essentially this is after the 60 minutes are met, each additional 30 minutes of clinical staff time per calendar month. And you're not able to build this code unless you've met at least the 60 minutes. And again, these are month-to-month codes. So where these codes currently sit, so they're currently considered a status B, which is a bundled code. What that means, my understanding is bundled service means payments are included in payments for other services not specified. And then separate payment for these codes does not exist. So my understanding, if anyone's more of an expert on this, is essentially what they're saying is, well, when you see a patient, you bill like outpatient established level 5, you're already getting paid for doing this. So we're not going to pay you for this code. And that's at the Medicare rate. So with that, Utah Medicaid also, and I just checked on this, I don't know if people use this Medicaid lookup tool at all to see our code. It actually says covered by Medicaid, but it's not. They also consider it a status B code, and they do not pay on this code, even though their website says that they do. That being said, we did actually see some commercial reimbursement in Educators Mutual. And we actually did see some Medicaid reimbursements. And so what that was ACO plans were covering it, not knowing that they didn't have to cover it, is by thinking. And so we did see a little bit of payment on these two codes. So my recommendations on these codes are really to proceed with caution. Again, where it talks about the high complexity and moderate or complex changes. That to me is a little bit scary in terms of defining that. And when I look at the 994, I know because it's the code that Medicare is going with right now to manage chronic care at the primary care level, I would think that would probably be the best bet. Also because it is only 20 minutes. I know the reimbursement's less due to that, but I think if you can actively manage those patients month to month. And then again, for this 87 and 89 code, the documentation and care requirements just appear to be much more rigid. I was mentioning this helpful website. So this is the Utah Medicaid lookup tool. There's also a link to this as well. But essentially, you can look up any code to see if it's covered by Medicaid, and then if it is, what they paid for that code. And kind of in our university setting, what we typically do is we identify anything that's covered by Medicaid and usually go off that rate as like a worst case scenario. This is what we're going to be paid when we're trying to figure out what our financials. So anyways, this can be helpful. It will also show like traditional versus non-traditional versus PCNs. Some of these codes may be covered. The 87 and 89, for example, I believe they're both covered 0 to 18, but then 19 and above they're not. And like for PCN, they're not covered as well. That's all I have. Are there other questions?
So before you go, and I said sadly that Julie had to leave, but I didn't hear her speaking up and saying that anything that you were saying wasn't accurate. So go with that for now. But so I did reach out to each of the ACOs to ask they're paying on me. I'm not sure that I hit the right person in every case, but I did make contact and hear back from everyone. So what I heard is that Select Health Community Care is paying on 99490, and that the other two codes are considered levels. They're not paying on those. Healthy U is paying on 99490, and they gave me the rate, so they're paying that 3365 rate. Health Choice said they're paying on all of them for traditional patients. So I might need to clarify that, or maybe I don't want to clarify that right now. So anyways, for what it's worth, the person I spoke with at Health Choice says they're covering all of those right now. And then Molina, again, I'm not sure I talked to the right person, and I have the contact to be able to go back and clarify if we want to do this. But they are saying they are not paying on any of these, that they are doing value-based reimbursement for contracted groups. And I'll tell you, I got the impression that at a pediatric level, this is a whole new thing for these groups. That it's the wild, wild west. So this is not my area of expertise, but that's what I was starting to hear. And with one of these, contract people, we had to be very specific, pediatric, because they're used to adults. So for what it's worth, that's what I gathered, and we can dig more deeply, although I think sometimes you can hurt yourself that way.
And I would say, so at the Medicaid level, so again, CMS didn't rule on this code. They put it into effect until January 1st, 2015. And these things just take time to get out there. So I spoke with someone at the University Health Plan, and they said, yeah, we'll pay on it, but we even internally haven't established like any criteria that we're going to have to set. And I think that's probably where most plans are. And even at the commercial level, again, I mean, it'd be great to say, let's go out and bill all this and get paid on it. But you do have to consider your commercial plan level that what if all of those commercial plans just decide not to pay on it because they don't have to. And then if, like Chuck brought up, if that all gets down billed back to the patient, at the clinic level, you probably want to be ready to have that discussion with families. They'll usually call and say, what is this? Especially if you're billing it every month and stuff. But yeah, if you want to reach out to me, I can answer whatever other questions you might have. Okay, thank you.
Thank you, Jason, so much. I really appreciate that. That was great stuff. Okay, well, so one of the things that I was kind of hoping to tease out of that last presentation was, what needs to be documented in a comprehensive care plan. And as with so much in care coordination, it mostly has to do with just figuring it out as you go along. But it's a nice segue into our next, I'll leave that up for just a minute, our next part of the meeting, because what we'd like to do is talk a little bit more about care plans, and specifically care plans that could in fact ultimately be shared by providers. Because, I mean, that's kind of the point, right? So in the stack are pens. You'll notice that some of them are super fabulous because my daughter put these pens in here, so if I could get them back, that would be great. But take a pen, take a couple pieces of paper, and we're going to have a little interactive session here about hopefully elements of a care plan that you, in your practices, would find beneficial. And so the idea here is for you to imagine if you had a complex patient, maybe not too complex. Jason mentioned some of them might have 20 things going on, and that for the purposes of this little exercise, let's go a little bit less complex. But still, not your kind of typically developing, but some that have a number of things going on, and maybe they are working in that with a specialist or two. And if you had information coming back from that specialist in some form, what would be useful to you in your practice at that primary care level, and in what format would it be helpful? So this is use your mind, go crazy. You can take as much room or as little as you want. We've got plenty of paper. You can start by just listing kind of those pieces of information that you would find is really important and basic and required, and then maybe go from there. talk about the other things that would be helpful. You can mock up a form if that would be of value to you, if you're a visual type of a thinker. But take a look at these criteria and then go for it. And then I'm going to ask you to kind of yell those out, and I'll write them up here after you kind of talk through it for a few minutes. people not writing, so I think I'll go ahead and jump in. Okay, so for our shared plan of care, who wants to start? I'm throwing something out that would be your required element. Sorry.
Trying to hide over here.
Yeah.
Start by establishing
Problem list, okay?
Share team's names and contact information and what they're responsible for.
Oh boy, okay.
Any diagnosis that might exist.
Medication list, medication.
Okay, what's already good,
Like
Okay.
such as labs and things like that.
okay? So I think that might be where it gets tricky. In fact, I think probably all of these to one degree or another, right? Because how far back do you go, or how much detail do you provide? So, okay. Anything else? Any resources that you recommended to the patient, including contact information for those resources? Okay, and by that do you mean referrals as well? Referrals for our community, yeah, okay. Support groups.
I would just say, I don't know if you want to go under subcategories, but under the problem or say diabetes, plans, autism, or whatever, that there were subcategories of like physicians, subspecialists they see based on that particular problem. Those under each particular problem.
Right.
That you're finding out.
So if we're thinking of this coming back from a subspecialist, they're probably only going to be putting their information in at that point. But if you're collating this somehow, then we want to be able to see all of it. So that's the care team information that's tied back specifically, right? Whatever the problem is in that column or treatment goals. What was that? Treatment goals? Goals, great, okay. So maybe it's like clinical goals, right? Okay. Okay. Great. Others?
When would they like to follow that patient up?
Okay.
And how long? For how long?
Okay. Anything else? This is good. This is helpful. Yeah, Marilyn.
So this is all for the healthcare child. When you're looking at the total family, you've got, do they have housing? Do they have transportation? Do they have food? And they may not be involved in that necessarily talking with your healthcare plan, but it's part of it. So sometimes knowing social situations and access to other
Social economic situation.
Yeah. Yeah. Really important.
It is very important because they help us, finding out the social and economic situation of families. It helps us to assist on ways so that we can get them to the appointments, such as they don't have a car right now, so there's Medicaid transportation available to them. We just need to know what the obstacles are so we can help them.
Right. So I have kind of in my brain maybe to some degree a form where you check a box rather than have to type it all out, right? You're prompted somehow maybe and transportation, yes, no, or something like that. Because rather than having, perhaps paragraphs about what the social situation is, it would be, okay, can they get themselves to the appointment? Yes, so, and then no, something else. Hang on, Marilyn.
Oh, sorry. So I think also it's very important to have at the top of the list coverage or health plan.
Okay.
To determine, that's gonna help determine everything basically.
Good. Okay. Okay, Marilyn.
And also, because these are children, we need to know what's happening with their learning. Are they working with school, child needs?
Okay. So I can see that to do it right, it can get pretty big, right? And I think that's the trick, is to try and understand how to synthesize this for a given situation, a given opportunity to share it. Because each one of those would be a little different in the kind of information that we need, right? I find this overwhelming, and I'm just thinking about it theoretically. You guys do it every day, so this is a big deal, and it's a big problem to try and tackle. So switching now maybe briefly to the idea of format. So let's say that somebody really was trying to provide you some information. How would you be able to bring it into your system so it could be actually documented and saved? What does, not necessarily trying to get into a highly technical discussion about EMRs and their abilities right now, but I'd be curious to know, do you guys scan things into the record?
Yes.
Everyone's nodding, okay. So at that point, like PDF versus Word versus whatever, it doesn't matter because you've got a physical piece of paper that you're scanning in, and then what does it go into the system as? What kind of format at that point does it go into? I mean, it has, the scanner has to save it as something, right?
Media.
That's all right, okay. And then once it's in the system, how hard is it to see it? Is it structured in such a way that within the patient's record it's easy to hop over to those scanned things? Some nodding, I think some not sure.
Yeah,
some
not in Epic.
maybe not
Yeah,
so easy.
not that easy.
You don't think so?
Yeah, especially if it's mislabeled.
Yeah, that's
Oh, that's
Yeah, and you have to
Now
open it
labeling.
several. Yeah.
Okay.
When it's all adding.
Oh man, okay. So titling, is titling different than labeling? So how do you see it in your system? I mean, you see it as the name of the document that's going to
So with Epic specifically, it's a little tricky because we have no control, over, how it's going to be
label
named.
it. Yeah.
So we scan the document physically, but someone else in a different department is in charge of naming or putting it under.
So it will say outside record or clinical records, but it's not specific.
In the beginning, it was nice for us because the doctors were able to name whatever they wanted that document to be named, but that changed, and now it's up to the other department to put it under whichever
The unknown
files
department.
that they've seen.
Anybody else have a similar setup where you got multiple areas of your overall organization that are involved? Some yes, some no. Okay. Very complicated, isn't it? Jason was talking about just doing some PSA cycles to understand, billing and if it's worthwhile or not. And he talked about needing the billing department, the IT department, and then certainly the people actually doing the work, and providers. They have to be involved because they have to be the ones to drop the charge, right? So now it sounds like we might have to involve others as well if we want to make this an efficient process. So, okay. Do you guys have IT departments who would be willing to try and do something a little more custom? We brought this up before, it was a while ago now, about EMRs having the ability, it's not certainly, I can't say it across the board, but I think more and more to have some sort of customized template. Is anybody doing that in their departments or in their practices? Again, that's probably going to come back to not only having an EMR that's at that point or that you put the add-ons and all the other money and those we're into, but also to have the resources like the IT folks who would prioritize that. But for right now, if you've got a written something or other, you would be able to consume it. It would just be a matter of hopefully it showing up appropriately.
You couldn't update it then.
Yeah, it's not updatable at that point. It has to be replaced every time. That's to be so the date would be a good thing on this, right? Okay. You guys, this has been really helpful. This is not something that we're going to set down anytime soon, so we'll probably come back to periodically and talk a little bit more as some other groups and some other efforts around care plans and particularly sharing those care plans continue to move forward. But your input is so helpful. If you think of more about this, if you have a light bulb go on, shoot me an email. I really appreciate it. You guys are the ones who actually do this on a regular basis, and we would value your input greatly. And I hope that we didn't ignore anyone who's on the phone.
No, I kept watching.
Okay, so I hope they did this along with us as well. But yeah, kind of going back to these billing codes. So you're required to have a care plan, right? Is everybody doing that? Complex patients? Is everyone doing a care plan? I mean, this is a loose term, right? We don't have that hard. So, I mean, I guess we're getting to a point where that's going to have to be done to some degree if you want to get reimbursed on that 99490. So, would having some examples of care plans be helpful to folks? If we put some links out to those, would that be of use? Okay. So, you'll probably be getting a lot of links in the email that goes out. We'll have links to Jason's examples of consent forms. So that's clearly very important. We'll have some links to care plan examples. We'll send out the Medicaid lookup form link and probably a bunch of other things that I've missed. But all of that will go out probably by Friday. And the recording. Yeah, all of those. Yeah, exactly. And everything that we talked about with regard to loss insurance. Very good. Well, as we wrap up, just want to remind you our next meeting will be on February 17th. We'll be back here again, weather permitting. And then, as a matter of fact, it was Jason Fox who sent me an email. It was actually back in December, but reading through it, I think that it looks like the opportunity for this isn't necessarily time-bound. And through the university health plans, they were being informed of some case management seminars, and it looks like they're free. There's continuing education units that you can get through those. I don't know if anyone would. Does anyone need case management continuing ed in our immediate group right here?
I'm always open to learning anything more.
Yes. So I'll try and synthesize what this says and send it out, and we'll make that part of it. But it looks like there's some opportunities through someplace called Summit Reinsurance Services, I think, for motivational interviewing, which I think is always a wonderful skill to well, I don't know who can master that, but to learn. Another one that's about case management, everything you wanted to know about case management, but we're afraid to ask. And finally, transitions of care. So again, this will be coming from more of a case management perspective, but yeah, those might be interesting. So I'll try and send out some information about that, and maybe certainly some of these more organized, folks like the university health plans would be arranging something, but maybe we can even consider arranging something for members of this group. So I will send that out as well. So with that, we're done a few minutes early. You can deal with whatever weather is awaiting us. Please help yourself to some more food on your way out. Thanks, everyone. Really appreciate you coming. Happy New Year.
Thank you, Mandy.